I was asking Sung Ho whether I should talk about complications early and late, or whether I should specifically talk about technical complications, and he suggested I would do more on the technical side. I think of all the different types of interventional procedures in congenital heart disease, stenting is one of the more complicated ones in terms of techniques, because there's so many little things that can go wrong that can cause problems. So I'm going to spend a little time just really talking about technical issues in pulmonary artery stenting. So these are some of the things that we see that always make nightmares. So here's an example of a balloon. Everything is in position. You inflate the balloon, and of course the balloon opens, but the stent does not open, and next thing you see contrast in the vessels, and you say, uh-oh, there's a problem. So that's one type of complication you might see. There's another complication. The balloon is not exactly centered on the balloon, but you say, that's okay, let's just keep going. So we inflate the balloon, and instead of the stent going inflating, it slides off the balloon. Now you have a half-open stent, and it's not in the right place. The third one, the stent is in good place, but for whatever reason, it embolizes now, which is flowing in the air, in the breeze of the flow. And of course, these are the things that make you tachycardic, like Omar says. All right, so how should we take care of this? How should we anticipate these problems? So there are many limitations and pitfalls in pulmonary artery stenting. First of all, we don't have any stents that are officially approved for congenital heart disease. Everything is used off-label. Most of the stents are adapted to adult patients, not to kids. The delivery system and the stents have to cross the right heart and two valves before getting into the pulmonary arteries. The stent malposition and balloon rupture is what we're going to focus on. We'll talk about how to avoid them and how do you manage them. So I sort of break it down into four main phases of stent implantation. Number one, we're going to start with a well-thought-out plan of the anatomy of the pulmonary stenosis so that you have a strategy to take care of it. You have to have accurate assessment of the anatomy and the appropriate selection of stents and balloons. We'll go to the second phase later on. So this is what I'm going to talk about first. So this is, first of all, we know that all branch pulmonary stenosis are not equal. This is a discrete stenosis in the middle of the branch. This is quite easy to take care of. The stent really is hard to slip one way or the other. But sometimes the stenosis go up to the lobar branches, sometimes it's at the orifice, and you're dealing with hypoplastic lungs, as we've mentioned previously. So in a kid like this, very easy to take care of. It's mid-branch. This is the easiest ones. This is the medical student version of pulmonary artery stenting. This gets a little harder because now you have to go distally. But when you see this, the strategy has to think about how am I going to take care of this first. Here we put a stent in here, and then we follow through with double stenting in the upper and lower branch. So again, you have to plan this out in a very careful way so you don't make a mistake. If you put the double stents in first, it's going to be a lot harder to put a single stent proximally. So you start proximally and work your way out. So these are some of the things you have to think through. Obviously, in the kid with hypoplastic pulmonary arteries, the stent can still slip, so you have to be very careful. Pre-dilation, making sure there's good compliance and low resistance before you put the stent in is important. So we have to be familiar with the adjacent anatomy. We don't see this too often, but sometimes we do. So here's a picture, a simultaneous injection of the MPA. You see the LPA drapes around the dilated aorta. So therefore, you're saying, okay, we're going to have to stent the LPA, but we have to make sure that the adjacent anatomy is actually adequate. So here's the example of the aortogram. Again, this is in a Norwood type situation. And so we do a simultaneous injection. So you see, we take the picture in the MPA, then we follow through with the aortogram. And you can see that not only the ascending aorta is a problem, but one of the coronaries may be a problem. So in that situation, we don't want to risk causing a compression to the ascending aorta in this case when you put a stent in. So these are the kind of things you have to make sure you understand before you proceed with stenting. So know your adjacent anatomy. You have to center your anatomy in the center of the camera. Now, this is a little grid that we put on the camera. You see that there's a waviness, right? That means that the lens is distorted. Now, the newer cameras with the image intensifiers don't have as much of a problem, but there's always going to be a little bit of variation. So if you're going to take a stent, you're measuring millimeters, put it in the center. Don't do it at the periphery. So here's an example of a balloon on two equal size spheres. You see how the edge sphere has distorted because of that. Same thing with the height, right? If it's lower, it's going to be more magnified. And this is higher up. So again, just a 9-inch difference, you see that there is a size difference. Again, make sure you put your anatomy of interest in the center of the field. You have to make sure that your anatomy is well featured first. Here's an example of a RPA stenosis. And if you took this picture, you might say, okay, well, it looks very good, let's go on. Until you start angulating, you realize there's another tight stenosis in the LPA orifice, which might be hidden behind the MPA. Again, you need multiple angles to make sure you understand your anatomy. Of course, now with rotational angiography, it's very useful to take the rotational angiography and then find the best angle to see the stenosis and use that angle to do your intervention. So of course, this is an example of a 3D rotational rendering. In this case, we actually did this in a very caudal view. And so this is the AP camera. You're going to have to go into the screen so you can highlight this area to see what you need to do. You also want to see how this area is related to the RPA to make sure that the stent does not jail the orifice of the RPA. Again, having the 3D rotation can get you the best angle, and then you use that angle to do your intervention. So let's go to the second phase. This second phase involves stent delivery to the target lesion. What can go wrong during that period of time? Well, first of all, when the stent is inserted into the sheath, the stent can catch the valve of the sheath and cause it to milk back from the balloon. When you're advancing the stent and balloon through the sheath, if it's around a tight curve, the stent can also milk back over the balloon as you come around the curve. When you're positioning the stent at the stenotic site, unless it's well positioned, the stent also can shift off the center of the balloon during your fine tuning of the positioning. And of course, I say avoid using short sheaths. Always have a long sheath, even with the pre-mounted stents, because the stents have been known to slip off, even though it's not designed for that. So never take a chance. That's my opinion. So what I usually do is I will mount the stent on the balloon. I will use a umbilical tape to crimp it down so you have some circumferential pressure. Then we'll inflate it with a little bit of fluid inside the balloon so that it makes it tighter. Also, then you squeeze the balloon on one side so to force the fluid to go to the other side. So you develop a little bit of a fluid channel so that when the balloon goes up, it's even on both sides, not just on one side. So if the patient is bigger and you can afford a bigger sheath, you can actually put a larger sheath in, or you put a small cut sheath so that when the balloon and stent goes into the valve, it's protected by the short sheath so that the stent doesn't milk back. Look at this. This is the catheter, Mullen's catheter. If you look over here, the internal lumen is circular, but when it comes to the turn, it can become more oval. So this is where the stent can get caught. So when you're advancing your sheath and balloon, a stent and balloon, make sure that when it's coming around the bend, that the stent doesn't milk back from the sheath. So we can actually put a short sheath in and front load the stent and the balloon on the longer sheath if you can afford the largest diameter in the veins. Sometimes in the babies, you can't do that. But nowadays, with the more low-profile stents, and we tend to use a lot of Max LDs, Genesis XDs, and the pre-mounted Valleos now, they're much more flexible, lower profile, and they have very smooth edges. So the newer stents actually have some advantage over the old Palmar stent. Oops. So when you're stenting, when you're positioning, you want to optimize your stent position at the stenotic site before you actually withdraw the sheath. If the stent is not centered on the balloon, you might want to adjust that stent before you actually inflate, just like what happened when I showed you earlier. If you don't do that, the stent might slip off the balloon. So the stent can slip back. If the stent slips back, you can take the edge of your sheath to push forward to center the balloon. If the stent is slipping forward, you might have to use a snare catheter to pull it back. So here's an example of the stent being off-centered. And again, I would never want to inflate here, but this is exactly what we did. We were late in the day. We said, let's just try it. And of course, this creates a nightmare, right? The stent is half open, it's sliding forward. We don't want that to happen. So here's an example where the stent is slipped forward. You put a snare in there and you pull it. And by doing that, you can recenter it so that you don't have the problem with the complication. It takes a few extra minutes, but it's going to save you a lot more for the future. So here's the same patient. We snared it. We took the snare out. Then we inflated it. So everything goes fine after that. So here's an example where the stent slipped backwards. See how the radial opaque markers of the balloon, the stent is backwards. Here is the tip of the sheath. You can't hardly see this, but if you put the sheath up against the stent and pull the balloon, you watch on the lateral better. You'll see that we can actually recenter everything so that with that you can inflate the balloon better. So sometimes the stent can slip. So again, try to, if you see that, fix it before you keep going to the next stage, because that can create a problem. Let's go to the third phase. Now the third phase is the balloon inflation and the stent implantation. What could go wrong there? Well, first of all, the balloon and stent can shift out of position during inflation. The whole thing can either move forward or backward depending on where. Usually it's at the orifice where there's an angle. The balloon can rupture during inflation. And again, the sharp edges of the stent can cause a pinhole. Calcium can cause pinholes or even circumferential ruptures. You have to be aware of that in advance. The stent can also slip, like what I just showed you, when it's not well centered. So here's an example of a stenosis in the LPA, and we put the stent in, and we noticed that here we missed a little bit of the proximal stenosis. So we went ahead and put the stent in. Again, I already showed, I probably didn't save this on the fluoroscopy, but the balloon is inflating, and as we're inflating, the whole thing slipped forward. Now, it's very important to inflate very slowly. I've seen people go very fast. If it goes fast and something goes wrong, you have no time to make an adjustment. So I always inflate slowly to see a little dumbbell here before we can do up. In this case, the balloon partially inflated, the whole thing slipped forward. So here what we did is that we have time to stop. We can now pull everything back and readjust this before you inflate. And then with that, you can go ahead and improve your improvement. If you inflate very fast, you won't have time to make the adjustments. Okay, if it's a very high resistance, I tend to do predilation to make sure that there is some compliance in the vessel. Sometimes you have to use a cutting balloon to get rid of the waste before you actually put the stent in. If you don't do that, the balloon can slip, and the stent can slip with the balloon. So again, it's important to make sure this balloon is stable with the stent on it. Another thing can happen is a balloon rupture, right? The stent is inflated, the sharp edges of the stent can puncture the balloon, and there's calcium that can cause a problem. You can have three types of ruptures. One is a pinhole, one is circumferential, one is longitudinal. And if that's a pinhole, which is most of the times you see in the stent rupture, first of all, you want to avoid the excessively long balloons. Second of all, avoid the low pressure balloons like the Tyshak 2s or the minis. Bib balloon is actually very helpful because the inside balloon opens up, that evens out the whole stent before the outside balloon goes up. And that helps to maintain evenness of the stent. Avoid aggressive crimping because that can also cause the edge of the stent to pinhole the balloon. The newest stents, like I said, the Genesis EV3 Vallejo, much easier. The Vallejo has been another workhorse for me because it's already pre-mounted, so you don't have to crimp. You inflate, if it's bilateral stenting, you want to inflate and deflate simultaneously so the edge of the one stent does not puncture the other side of the other balloon. So be aware of a lot of maneuvering because that can also cause pinhole ruptures. So here's the old Genesis, the old Palmas. See how sharp these edges are? The newer ones are much softer and much rounder to avoid or minimize the risk. That can still happen though. So here's an example, another one that we had, I showed you on the one where you inflate the balloon and suddenly you have a pinhole rupture. And in this situation, one of the things you can do is you, instead of using your, you take off the inflator, put a small syringe in. The small syringes tend to have higher PSI. So if you push really hard, the amount of fluid that goes into the balloon is more than what exits the balloon. And in doing so, you can still inflate the balloon to what you need if you use a smaller syringe. Sometimes you have to use a 1 cc syringe if it's a small balloon. So you can see how in the same situation, we just took off the inflator, put a 3 cc syringe with higher PSI, and you can actually overcome the pinhole. Now, this is an example that I did when I was do a live case demonstration in a pig model in Japan a few years back. I purposely mounted a stent on the balloon, and I purposely stuck some pinholes there just to prove the point. So here we're inflating this, and you notice that as you inflate, the balloon is not inflating very well. In fact, there are some pinholes over here. So see what happens here. See as we're going up, see how there's contrast falling out? We start with a smaller balloon, and we push hard, and we're able to push it a little more. Let me just go back a little bit here. And with that along, what I found that you can do is take your sheath, advance it over the balloon, see how the sheath is actually inside, the balloon of the radial marker is now inside the sheath. that covers the pinhole. So with that, you inflate the balloon, the pinhole is blocked by the sheath, and so now you can still inflate the stent. So you can, this is another trick, if you notice this is a proximal pinhole. And of course, with that, you've mostly inflated it, you can now adjust this. And again, now you notice that once you pull the sheath back, the balloon doesn't inflate as well, right? Because see the contrast coming out. But when the sheath is over the pinhole, it seals that pinhole and you can still inflate the balloon. So I think that's a nice trick to remember if you have a proximal pinhole rupture. So in the end, you can finish up with a bigger balloon and you can do this. So again, this is a good technique to get yourself out of trouble. Circumferential tears are a problem. So anytime there's calcium, I always pre-dilate to make sure the balloon doesn't break. If the balloon breaks, you don't want to do it with the stent on place. So always make sure that. I learned that because I made a big mistake myself in just going up with the balloon and the stent, and the balloon ruptures and it became circumferential. You have to make sure you remove all the pieces and make sure you don't leave any pieces behind. Sometimes you need surgery to help you at that point if it happens. So always pre-dilate with a balloon. I'd rather deal with a ruptured balloon without a stent than with a stent. The new balloon, high pressure balloons are made of Kevlar, the APCIS, there are other couple of ones, but the APCIS is they're made of Kevlar, so it's very strong and they're very good for this kind of situation. Here's the example. I've shown this in other talks before where there's calcium. We actually see it in both AP and lateral. There's simultaneous inflations, and you notice that the one on the right suddenly disappears at the balloon because it popped right here. And of course, as we're pulling this, the balloon is coming out, and the balloon is out, but the distal marker of the balloon is still in. This is one of the few times where I had to send a kid to surgery on an emergent basis because there's no way I can take that piece out. So there you see it. And of course, in the OR, you see this balloon ripped in half, a circumferential tear. So again, since then, I've been very respectful of calcium. Here are some of the calcium spicules that they pull out of the conduit. So again, if you were to do this, test it with the balloon first before you put the stent in. Now, what else can happen when you inflate? The stent can milk off the balloon during inflation, forward or backwards. So here's an example, stenosis in the LPA. Watch what happens here. As we inflate, the balloon slips forward. So now suddenly the stent is off-centered. So in this case, because the stent is a cone, you can actually pull back with the sheath holding the stent so it doesn't slip too far back, and then try to pull the balloon back into the stent. So you see how the stent is now pulled back in there, not all the way, but enough that when you inflate it, you can make the stent a little bit bigger. And then we do this multiple times. Each time you pull the balloon back a little bit more with the stent, with the sheath holding the stent so it doesn't come too far back. And you keep doing this until you see now finally the balloon is centered and now you can fix the whole thing. Obviously the stent is not going to be in perfect position. You know that's going to happen, but it's better than having to deal with the embolized stent. So in this case, we'll put a second one in. And watch what happens with the inflation. We inflate and see how just in the process of inflating, the whole thing just jumps forward. Again, that can happen when you inflate the balloon. Again, we had to go through the same maneuver. Again, inflating a little bit to secure the stent on the balloon and then pulling the whole thing back with the sheath holding this so that the stent doesn't come too far back. But now the balloon is recentered across the stenosis. And now when you inflate it, you can get to that stenosis. Again, it's important not to inflate too fast. Go slowly, and you can get yourself out of trouble, get a good result, and the family will never know you were sweating like crazy. All right, the last phase is removing the balloon. I always say it's not over until it's over. Just because the stent is in good position, it's not over yet. It's only over after you pull everything out, and things can happen there too. I've seen a lot of times people will inflate the stent, take down the balloon, and just pull it right out. Well, we know that the wings of the balloon is not in low profile after you inflated it. So the wings of the balloon can actually pull the stent back. So you have to be really careful. To avoid that, this is a trick that Dr. Mullins taught me. You inflate the balloon, and as you inflate it, you actually advance the sheath over the balloon so it's centered on the balloon. It doesn't touch the edge of the stent. And you do this multiple times. Inflate, deflate, inflate, deflate. Every time you deflate, you advance the sheath. As long as it stays in the center of the stent, it's not going to push the stent. So you do this until the balloon is all the way inside the sheath before you pull out. That way you protect the wings, the stent from the wings. So here's an example. Now I want you to focus on the top of the stent here. So you can picture trying to pull the balloon. If there's a wing here, the balloon can pull the stent out. But watch what I do here. So you're going to inflate the balloon, and as you inflate, you're going to deflate, and as you deflate, you advance the sheath. Now watch what happens. You inflate, see how the sheath is goes away, but suddenly the sheath is now up against the edge. You inflate again. See how you push it away from the edge of the stent every time you inflate, but as you deflate, you slowly advance. Each time, your assistant is going to inflate, deflate. You make the decision when to push the sheath, but this time, every time you push, the sheath is not against the stent. See how we can now pull out the entire balloon into the sheath, and at that point in time, the sheath can come out. And with that, you can make sure you avoid, see how now with the sheath, the balloon inside the sheath, you can pull it out, and that avoids the stent pulling out. Well, let me show you some examples of what happens when you don't do that. So here's an example. Well, I'll come back to that. So here's the balloon stent that's embolized. When you have a stent embolization, the key thing is to maintain good wire position. The general algorithm is that if the balloon is inside the stent and it's partially inflated, you can still try to recapture the balloon on the stent and recenter on the stenosis. If that's not possible, then you want to implant the stent in a safe place. It doesn't do any good, but it doesn't do any harm. If you can't do that, then you're going to have to retrieve it, either by surgery or transcatheter techniques. So that's the general principle of what you do with a malposed stent, or embolized stent. So what happens when the stent is a problem? Well, there are three things you can do. You can either reposition the stent in the contralateral vessel, because usually the contralateral vessel is big. So you can put a wire through, readjust it with the JR catheter, and find the other side to put the stent in a safe place. You can also try to telescope an embolized stent with a longer stent to stabilize it, and I'll show you an example of that. Or you can pull the stent down into the IVC if it's still on the balloon, but you have to be very careful with the tricuspid valve. I tend not to do that if I can avoid it. So here's an example of a stenosis. My colleague inflated a stent. He was very happy. So guess what? He pulls the balloon out, and this is the picture afterward. Again, remember I said it's not over till it's over? So by the time he pulls the balloon out, the stent is in the MPA. It's no longer at the stenosis. And that was because he didn't use that technique of making sure the balloon comes in without dragging the stent back. So what he did was actually very smart. Okay, so here's the stent that's embolized. You can stabilize it with the sheath, but you put a longer stent in, and see how the longer stent is sitting in across the stenosis, but here's the embolized stent here. And then you can pull back and then pin the embolized balloon with the sheath against the stenosis here, and then you can inflate. So by doing that, you're anchoring the embolized stent over the longer stent that crosses stenosis. So the longer stent will stabilize it, open the stenosis. The outer stent that's embolized, at least it's stable on the outer balloon. Now, of course, the problem with that is that it jails the other side. But luckily, there's not a lot of obstruction to the flow, so that was left alone. Not perfect, but it gets you out of trouble. So a lot of times when you get into trouble, it's important to just de-escalate it. Don't worry about perfection at that point. Another example, LPS stenosis, one of my colleagues put the stent in and just pulled back. And guess what? As the balloon came back, the stent came back too. Again, this is really important. Don't let your guards down even though everything looks good up until this point. So of course, luckily this is a Fontan. So the balloon inflates, you can drag it down to the IVC and basically implant the IVC. Not useful, but safe, and then you can go back and take care of the other side. So let me summarize that. Limitations and potential problems can be overcome with new design stents. You have improved stent delivery techniques and very careful advanced planning. A complete strategy for the intervention and any anticipated problems should be thought out before each case. A full armamentarium of supplies and devices for retrieval should be available if you're going to do this. Become very familiar with repositioning and retrieval techniques. Finally, you have to have accurate measurements of the stenosis, know the adjacent anatomy before you select the right balloon and stent, anticipate and monitor for potential problems, be prepared to handle the complications. And to me, it's always important, details, details, details. It's the little things that are done in the stent procedure that can help or hurt you. Thank you.